Good afternoon everyone, this is the surgery resident. Today we will be discussing all the questions that were given in Neet SS 2025 surgical group. As I have observed, there are many questions that were given from Sabiston. Likewise, which the last year they were mostly from the Bailey and 30% from Sabiston. But this time most of the questions were directly given line to line from the Sabiston. So firstly, we will be discussing regarding the lymphatics questions. There are a total of 4 questions from the lymphatics. So the first one is, what is the false statement regarding lymphoscintigraphy? Among the given options, the first one is a false one. It can differentiate between the primary and secondary. Generally, it cannot. It is associated with exposure to small amount of radioactivity. It is a true statement. Migration within the skin and subcutaneous can be monitored by whole body camera. It is also true. In edema secondary to venous diseases, the isotope clearance is abnormally rapid, which is given like just line to line in your Sabiston. Here you can see. It cannot differentiate between the primary and the secondary lymphodemas, and there is a small exposure to radioactivity, approximately 5 millicuries, and the lymphatics migration along the whole body can be monitored by a whole body gamma camera. And also in patients with edema secondary to venous diseases, isotope clearance is usually abnormally rapid. So we can see that each line, just line to line, was given from a paragraph in the Sabiston relating to the lymphoscintigraphy topic. Okay. The second question is, what is the true statement regarding this procedure? He has given this image which is showing the Charles procedure. As we can see, he has asked what are the true statements regarding this procedure. First one is, it involves excision of skin. It is not true because it involves even the excision of skin subcutaneous and even the deep fascia. Second one, skin graft uptake is 28% only. This is also not true. This procedure is done in when skin is unhealthy and infected. This is a true statement. It is a stage procedure. No, it is also done in a single stage. Again, you can see in the Sabiston line to line. What he has given here is, see here, in this case the classical excisional originally by Charles is performed when the lymphedema is extremely pronounced and the skin is unhealthy and infected. So here, when the skin is unhealthy and infected, this procedure involves complete excision of the skin subcutaneous and deep fascia. This point was not given. That's why the first statement is a wrong one. And this is performed in a one stage. It is not a staged procedure. And here you can see that the skin graft take was 88% following surgery. So this will be the true statement. The next question is, in lymphedema, reconstruction was done with lymphovenous anastomosis. What is the type of surgery? I could only recall two options. There were microsurgery and super microsurgery. And in Sabiston, in a small diagram, he has given this, like written that this reconstructive microsurgery of lymphatic vessels. It is a method of venous lymphatic interposition grafted shunt. This is regarding said to us microsurgery. In all the books, I could only find this reference where they have clearly mentioned this is the reconstructive microsurgery of the lymphatic vessels using lymphatic venous anastomosis. So according to this, the most suitable option will be the microsurgery as for the lymphovenous anastomosis. The fourth question is, which of the following is not a procedure for thoracic duct injury? The answer here is thoracic duct bypass. Why? The same thing, everything is written, given line to line. Everything is given line to line in Sebastian. So the first is non-operative treatment. Patient is treated with tube thoracostomy, median chain triglycerides, or even TPN. And octreotide or somatostatin therapy can also be given. These are the non-operative methods. But when it is associated with effusion that persists more than 1 week, then we try to do appropriate diet, octreotide and thoracostomy drainage, and an intervention to identify and occlude the thoracic duct above and below. So the operative procedure is to ligate the thoracic duct above and below the leak. However, there is a new technique using lymphangiography, that is thoracic duct embolization. This is the new technique. For any cancer related chylothorax, you can simply do pleurodesis if it is resistant to chemo and radiotherapy. It is highly successful in preventing recurrences. So there is no mention regarding or no procedure regarding saying any procedure like a thoracic duct bypass. This is not a procedure for thoracic duct injury. As you can see, they are like picking up each and every line from the Sebastian. So they have to be very thorough with the Sebastian for the next exam. Thank you.